Good evening, all. I welcome you all to the Image Journal Club, 23rd November 2023. So this happens to be our 13th Journal Club after what we have started around a year back into the activity, the serial activity that we do every month. So this time we have got something very interesting. We have a slight change of format this month. Every month we have journal scan, but this time in lieu of journal scan, we have got some data review on a topic which is very close to everybody's heart in plasma cell dyscrasia field, that is amyloidosis. So as we all understand, managing amyloidosis is very difficult. So today, firstly, we will have an article of birtamimab in light chain amyloidosis with cardiac involvement, the VITAL trial. So we have Dr. Fahima Hassan to take us through the article, to critically analyze it, and to give her comments about the article. And thereafter, we have our national expert, Dr. Pankaj Malhotra, sir, Prof and HOD from PGI Chandigarh. And we have Dr. Shaji Kumar, the international fraternity and the international founding member for the Image, to discuss about this particular article in detail. And following that, I would request Sumit to present his data. So firstly, I would like to request Dr. Fahima, who is currently Associate Prof at University Institute of Medical Sciences. Over to you, Fahima.
Thank you, sir. Am I audible and the slides
Yes.
visible?
Please go ahead.
Yes.
First of all, I'm very grateful for this opportunity, and thanks a lot to the Image for this opportunity. Today, we'll be talking about this trial which was recently published at Blood. Birtamimab plus standard of care in light chain amyloidosis, a phase 3 randomized placebo-controlled VITAL trial. I have to say I have no conflicts of interest. So just to set a background for this trial, AL amyloidosis, it's a low tumor burden, clonal plasma cell dyscrasia. The plasma cells produced misfolded lambda and kappa light chains, which forms toxic aggregates and amyloids depositing in vital organs. So early symptoms are very vague, and by the time the patient presents to us, it's pretty late. So these light chains become misfolded and they form prefibrillar aggregates and they form amyloid fibrils, and they deposit in all the vital organs except the central nervous system. So by the presentation is mainly because of amyloid deposition. So by the time the patient comes to us, there is organ involvement that causes the presentation. So not only the amyloid fibrils, especially in the heart, the prefibrillar aggregates which we see here can also be directly cytotoxic. So what is the history of randomized controlled trials of plasma cell-directed therapies in AL amyloidosis? As we saw, there can be two ways of approaching this disease. Either we can completely eradicate the clonal plasma cells producing the light chains and thereby leading to amyloidosis, or we can target the amyloid protein. But all these years, we have been targeting the clonal plasma cells. The first trial was by Kyle and Gray in 1978, where he compared melphalan prednisolone versus placebo, which showed some organ response, but it was not statistically significant and there was no OS benefit. In 1996, Skinner et al. Compared melpred colchicine, assuming colchicine will have an effect on the amyloid, but and definitely melpred colchicine was better than colchicine, and overall survival curve started separating after 5 months of therapy. Again, in 1997, Kyle et al. Showed that the benefit is mainly because of melphalan and prednisolone and not because of colchicine, again by a randomized controlled trial. Melphalan is working good. So what about high-dose melphalan followed by stem cell rescue was answered by IFM, but then they showed a worse survival in the high-dose melphalan arm. Then the bortezomib proteasome inhibitors came, and we were analyzing by RCTs whether induction prior to high-dose melphalan and stem cell transplant will improve outcomes. So it did, and drastically. We had a 2-year overall survival of 95% versus 69%. And the most recent RCT in amyloidosis, as we all know, is the Andromeda trial, which turned out to be a game changer with impressive hematological CR response and an overall response of 90%, and a significant improvement in progression-free survival and organ response, but no OS benefit. So what all the standard of care therapy was targeting the plasma cell clone. So we have gone a long way from 1978 till almost to 2023, and all the therapies which we are using in our routine practice are plasma cell targeting. So what about the other way of trying to reduce amyloid depletion? So there were a lot of drugs that was tried, cyclin derivatives and EGCG, which is a green tea polyphenol, but then no additional studies were conducted, or there were no RCTs to establish the superiority of these drugs. So very recently, desamizumab, a monoclonal antibody against SAP with poor risk-benefit ratio, was also tried, but of course, it did not come into clinical practice or did not reach the phase 3 because of very high risk-benefit ratio. So we have an unmet need in the other arm of approaching this very rare and disease with high mortality, anti-amyloid therapies. So we had initially tried these native state stabilizers, anti-SAP monoclonal antibodies, and even doxycycline. So a phase 3 trial is right now going on with doxycycline. And now we had tried this anti-amyloid monoclonal antibodies. There were two drugs which were being tried, a NEWD001 alias the bertamimab, it was named recently, and CAEL101. The difference between these two drugs is like that of daratumumab and isatuximab. NEW001 is a fully humanized one, whereas CAEL is a chimeric monoclonal antibody. So what is bertamimab? Nice IgG1 antibody, broadly binding to both kappa and lambda aggregated light chains. It was initially tried on systemic AA amyloidosis, and then they found that they are also working with AL amyloids. The epitope is very well defined, highly conserved, and specific to misfolded forms of light chains exposed to all stages of aggregation, including soluble aggregates, that is the one which is directly toxic to the cardiac myocytes without even the space occupying lesion in the heart. And this promotes clearance of the amyloid deposits via phagocytosis, which we can see in this image, where the small particles of the AL amyloid, and we have the macrophage. And in the presence of bertamimab, there is phagocytosis indicated by red fluorescence. This is in the mice models. So we'll come to the study right now. So what was the study design? It was a phase 3, multi-center, global, double-blinded, placebo-controlled clinical trial conducted between 2016 and 2018 in newly diagnosed treatment-naive AL amyloidosis with cardiac involvement. 260 patients were recruited from 70 international sites. This trial aimed to evaluate the efficacy and safety of bertamimab plus standard of care following a phase 1-2 trial versus placebo and standard of care. But a futility analysis was done after 103 primary events. The trial was terminated early because there was no significant difference in the primary composite endpoint between the two arms. But post-hoc analysis showed significant improvement in the primary endpoint in the highly frail Mayo stage 4 AL amyloidosis patients. And here we have the recently published paper. So what was the inclusion and exclusion criteria? Patients aged more than 18 years with the biopsy-proven diagnosis of AL amyloidosis were enrolled, and the additional eligibility criteria mandated a cardiac involvement. It could be clinical signs and symptoms supportive of a diagnosis of heart failure in the absence of an explanation for heart failure other than AL amyloidosis, or an endomyocardial biopsy demonstrating AL amyloidosis, or an echo demonstrating a mean LV thickness at diastole more than 12 millimeter, NT-proBNP more than 650, and must be less than 8,500 picogram per ml, thereby ruling out our stage 3B cardiac amyloidosis. eGFR should be more than 30 ml per minute. And the key exclusion criteria was non-AL amyloidosis, meeting the diagnostic criteria of myeloma, eligibility or plans to undergo an autologous stem cell transplant. So the baseline staging, organ and QOL assessment, how was it done? At the last screening visit, day -2 or day -1 before randomization, the severity of AL amyloidosis was determined using the 2012 Mayo Clinic revised staging criteria. Blood samples were taken for the assessment of hematology and chemical parameters, including TROP-T and NT-proBNP by the central laboratory. Other assessments included serum free light chain to check for hematological response, urine analysis, 6-minute walk test, and completion of short form 36 questionnaire version 2. So how was randomization done? Patients were stratified based on Mayo stage 1/2 versus 3 and 4, renal stage 1 versus 2 and 3, and a 6-minute walk distance of less than 300 versus 300 meters, and were randomly assigned in a 1-to-1 basis for either bertamimab or placebo. So the bertamimab was given at 24 milligram per kilogram, which was a maximum tolerated dose in the previous phase 1-2 trials, up to a maximum dose of 2,500 milligram, versus placebo, which was just 250 ml of normal saline with concurrent standard of care in both arms. All patients received concomitant standard of care chemotherapy, which included bortezomib containing regimen. Majority had a VCG regimen, almost 89%. Antiviral prophylaxis was required in patients receiving SOC chemotherapy. So what was the primary and secondary endpoint? The primary composite endpoint was a time to all-cause mortality or cardiac hospitalization. For all-cause mortality, all deaths occurring after the first infusion of study drug until the clinical trials, final subjects' last visit were included. The key secondary points were the change from baseline to month 9 was the physical component summary score, 6-minute walk distance, and the cardiac best response, which was assessed by NT-proBNP. So now we are also going to discuss the post-hoc analysis, which is a major data which was shared by this article. Post-hoc analysis in patients with stage 4, Mayo stage 4 AL amyloidosis with a time to all-cause mortality at month 9 and change from baseline to month 9 in the performance status, 6-minute walk test, and the cardiac best response, just like the primary endpoints on the trial intended to do. Hematological responses better than or equal to VGPR by month 3 was assessed in patients with stage 4 AL amyloidosis. So statistical analysis for a two-arm clinical trial with 90% power, we needed at least 156 events, and we had included all 160 patients in this trial. So the distribution of primary endpoint in the two treatment groups were summarized using the Kaplan-Meier curve. The performance status SF36 V2 PCS score and 6-minute walk time change from baseline to month 9 was done by mixed effect model for repeated measures, and the same were applied for the post-hoc analysis. Cox regression model was used to estimate the hazard ratios and a 90% confidence interval. An effect modification analysis comparing the hazard ratios of ACM at month 9 was performed to determine whether the observed post-hoc treatment effect in patients with stage 4 AL amyloidosis was merely due to chance. The severity of the adverse effects were assessed using the CTCAE version 4. So these were the baseline demographics. So if we see the total of 260 patients with randomized as 120 for bertamimab and 130 for bertamimab and 130 for the placebo. And what we see is that it is actually very well balanced as per the age, gender, ethnicity, race, and age at diagnosis. Even the duration since AL diagnosis was very well comparable between the two arms. Even the baseline NT-proBNP between the two arms were remarkably similar. What about stage 4 amyloidosis? 30% of the study population were Mayo stage 4 AL amyloidosis, and largely they were both similar as well. And when we see, there is a slight increase in baseline NT-proBNP in the placebo arm of stage 4 AL amyloidosis, and the same goes for the TROP-T as well. So overall, patients in the bertamimab and placebo arms received a similar median number of drug infusions as well, which was 15.5 versus 40. The mean duration of exposure was 389 days for patients with bertamimab and 352 for patients administered with a placebo. In the overall population, median follow-up was 15 months for bertamimab group and 14.5 for the placebo. In patients with Mayo stage 4 AL amyloidosis analyzed post-hoc, the median follow-up was 15.2 versus 11.3 months respectively. So this was in the supplemental appendix. So the efficacy analysis, the KM estimate of the primary composite endpoint for all Mayo stage, that is the N of 260, was what we found in the futility analysis as well. There was no difference in the survival probability between the bertamimab and the placebo group. We can see they are all very parallel and are starting together and going till the end. So what is the KM estimate of primary composite point for all Mayo stage disease group? There was no statistical significance in the time to all-cause mortality or the time to cardiac hospitalization. So how was the change from baseline to month 9 in key secondary endpoints in the intention to treat patients? Even there, with SF36V2 PCS and 6-minute walk distance and cardiac best response, there were no significance or there was no group difference in all the group with all patients, the 260 patients. So let's move on to the post-hoc analysis. So all-cause mortality of patients with stage 4 AL amyloidosis according to the Mayo 2012. We can see here that the survival curves are separating within the first month between the bertamimab plus standard of care and placebo plus standard of care. 74% of bertamimab treated patients, median OS was not met. 49% of placebo treated patients and a hazard ratio of 0.4 and a significance value of 0.025. So this separation of the curve was sustained throughout the study. How was a forest plot of ACM? We see despite sensitivity analysis based on baseline characteristics, it confirmed the robustness of all-cause mortality benefit in patients having bertamimab. The effect modification analysis comparing hazard ratios for ACM at month 9 between patients with Mayo stage 1, 2, and 3 and stage 4 AL amyloidosis yielded a statistical significant interaction p-value for treatment and Mayo stage, suggesting that the disease severity at baseline modified the effect of bertamimab on these patients. How was it changed from the baseline in quality of life and functional capacity? Again, in patients with stage 4 AL amyloidosis, the post-hoc analysis showed a significant improvement in SF36V2 and very minimal decrease in 6-minute walk distance time in patients with bertamimab plus standard of care arm. And both of these were statistically significant. And what about the cardiac best response, but in this post-hoc analysis? In patients with Mayo stage 4 AL amyloidosis, despite having improvement in functionality and quality of life, we did not see good statistically significant cardiac best response rate in patients with bertamimab with placebo. In the bertamimab and placebo arms, only 31.5% of patients achieved a hematological response, which was better than VGPR at the 3rd month, versus 28% of patients in placebo. So there was not much hematological response as well in these two cohort of patients. How was the safety? The drug was very well tolerated. As a matter of fact, the therapy emergent adverse events leading to death was more in the placebo arm than in the bertamimab arm when all patients were included. And the most serious therapy emergent adverse events were seen more in the placebo arm, even in the Mayo stage 4 AL amyloidosis. Overall, 41% died in the bertamimab arm and 41 patients died in the bertamimab arm and 42 patients died in the placebo. So there was no concerns regarding side effects of or adverse events related to the drug. So what was the most commonly reported grade 3 adverse events or serious events? They were all cardiac related, as we would expect in a patient with AL amyloidosis. Cardiac failure, pneumonia, congestive cardiac failure, where what was the most common adverse effects which was seen in the all patients arm. When we see Mayo stage 4 AL amyloidosis, again, the most common adverse events we came across was syncope, which was seen in 16% of the patients. Again, it was the same percentage in the placebo arm as well, and followed by cardiac failure, congestive cardiac failure and cardiac failure, which was also very comparable. As a matter of fact, was more in the placebo arm. So discussion, but let's come to a discussion of this. VITAL is the first randomized placebo-controlled phase 3 trial of an amyloid depleter therapy combined with standard of care chemotherapy in patients with AL amyloidosis and cardiac involvement. Because of early termination of the trial based on futility analysis, Post-hoc efficacy analysis were limited only to 9 months. Analysis of patients with stage 4 AL amyloidosis were conducted at month 9 as an efficacy endpoint based on median survival in the Mayo stage 4 placebo group, which was 8.3 months, and also to align with the key secondary endpoints. So in patients with Mayo stage 4 AL amyloidosis, significant improvement in survival with bertamimab plus standard of care was observed at month 9, as we all saw. In addition to potentially imparting a survival benefit, it also conferred a meaningful impact on quality of life by the 6-minute walk test and functional capacity by the physical component score in patients with advanced disease. Standard of care therapy is typically require more than 6 months to achieve organ responses. But most of the time, it's the first 3 months where patients with severe cardiac amyloidosis succumb. So we have to use other drugs like amyloid targeting drugs to improve the survival of these patients. No difference in the hematological response rates between the treatment arm suggests that the observed potential survival benefit with bertamimab was not due to the higher hematological response, which we saw in the other trials like Andromeda, and it was consistent with bertamimab's intrinsic mechanism of action. So this was the Andromeda trial, which showed an impressive hematological response of 78.5 at 6 months. But we could not find even at the third month, only around 20 to 30% of patients attained VGPR in this trial. So the authors concluded that this post-hoc analysis does suggest for the first time that there may be efficiency to an anti-deposit molecule in conjunction with the plasma clone targeting therapy, raising hopes for patients with advanced cardiac amyloidosis at risk of early mortality. Also, apart from improving quality of life and functional capacity of patients at the highest risk of mortality, it also exhibited a very favorable safety profile and was well tolerated, unlike what we see with daratumumab. Based on these findings and the unmet need in this subgroup of patients, a confirmatory AFFIRM-AL trial is currently recruiting under a SPA agreement with USF, where they are also incorporating patients who have taken daratumumab. At the time of investigation, it's going to be a 2:1 randomized trial, phase 3 trial, which only includes stage 4 Mayo patients. So now let's come to the analysis of this trial. Did the VITAL trial give us vital information? This was the first trial that has demonstrated a survival benefit in patients with Mayo stage 4 AL amyloidosis and with a favorable risk-benefit profile. The practice-changing and the only FDA-approved plasma cell targeted therapy with impressive organ responses, as we all know, is Dara-VCD. And that trial did not demonstrate a survival benefit at 2 years. So this was the appendix figure from the Andromeda trial, where we did not see a significant survival benefit in these patients. This post-hoc analysis suggesting survival benefit has led to the further trials giving some hope to the patients with stage 4 cardiac amyloidosis, designed to confirm the survival benefit observed in the VITAL study in patients. So the statistical analysis, coming to the statistical analysis. So what are not very good with the trial? The statistical analysis must be viewed with great caution, as the study was not designed for this analysis. Post-hoc data analysis confirmed to neither the population nor the randomization model of statistical inference. So the promising data could be nothing more than simple coincidence, despite statistical tests being done. Only 12 out of 38 in the treatment arm and 11 out of 39 achieved hematological response. This actually raises the question of the impact of earlier, more effective chemotherapy on the study outcome. Maybe a quadruplet regime, as we use in the based on Andromeda, maybe would that have given a better hematological outcome? As we all know, hematological response also correlates with some survival benefit. NT-proBNP has been validated as a cardiac biomarker, and decreasing NT-proBNP levels predict low mortality rates. This has also been emphasized on the phase 1-2 trials of bertamimab published by the same authors, because they did show a significant reduction in NT-proBNP in the phase 1-2 trials. Of 57% response rates was seen for responders in the phase 1-2 trial. But We did not see that in the post-hoc analysis, even in Mayo stage 4 AL amyloidosis. So again, coming to the survival curves, we see that either bertamimab is a game changer, or is it the group's variables, or it's a mere chance that we see that the curves are separating for the bertamimab and the placebo even within weeks of starting the therapy. The small number of patients and the short duration and the intrinsic statistics of this being post hoc requires further validation for this indication. So, thank you.
Thanks a lot, Dr. Paima, for a wonderful presentation and nicely deciphering the information which has been brought up. I totally agree with you that the article really does not bring forward any positive outcomes or the hope which was there for the people that it might actually help the people. So, but at the same time, I would say that this was the first of the molecules which actually has spoken about extracellular light chain deposits and something to act against it. Maybe the way the trial was performed, I like to hear from the experts that rather than they selecting all stages of amyloidosis, newly diagnosed amyloidosis, like for any other trial, drug trial, they should have taken only the worst possible patients, maybe only Mayo for stage 4 to start off with, and then would have on a later date added up something more. But still, I think I will open up the forum for initially Dr. Pankaj sir to give his comments and followed by Shaji sir to give his comments, please.
I think you have already made the comments and Faima has already made the comments. So I'll directly ask Dr. Shaji to make the comments.
Yeah, no, that was really nice presentation. I think you kind of hit on all the major issues with the clinical trial. So maybe starting off with the patient population, right? I think to Uday's comment, I mean, obviously we did not know or it was not clear whom we should target for a clinical trial, something with a new molecule like bertamimab. And it was all based on the phase 2 studies. And, there's probably from a scientific aspects, we don't know whom we should be targeting, but also from a commercial aspect, I think most of the drug companies would like to go after the entire population rather than really a segment. And you could make arguments either way, right? I mean, traditionally, a lot of the phase 3 trials, and Andromeda being a good example, they used the European modification of the staging system, but they excluded stage 3B patients. It's always concerning because the stage 4 or the stage 3B patients often have a 30 to 40% 1-year mortality rate. And so that is one of the reasons why patients didn't go on many of these clinical trials. So I think it's reasonable that they went for all the patients for that initial study, but the subgroup analysis clearly suggests there might be something. I mean, it's purely hypothesis generating. I think you hit on all the right points in terms of the drawbacks of this post hoc analysis. One of the things being, obviously, it's a small group. It's only about 30% of that entire 25 to 30% of the entire patient cohort that actually was stage 4, which is consistent with the distribution that we see in the general population, maybe a little bit enriched for the stage 4. The second thing, I think, what is most concerning to me, two aspects. One you already highlighted. One is the response rates, the cardiac responses. There's the discrepancy between what we are seeing with the cardiac response and what we are seeing in terms of the survival benefit. One could argue that, yes, since the study terminated at cycle 9, maybe we and we know that the time to organ response can be up to a year, especially with the cardiac involvement. So it's possible that the NT-proBNP decreases didn't quite meet the criteria, but may have been pretty close, but we don't have that information in the paper in terms of some of those end of treatment or longer term NT-proBNP changes. The other thing that is of interest, I mean, when you look at the historical controls, the stage 4 patients on the placebo arm did better than what we have seen in the real world cohort with the stage 4 disease. And that is something it's quite plausible. This is all larger centers enrolling on phase 3 trials. So it's already a selected patient population. So I think those are kind of the two caveats in the context of a post hoc analysis. But at the same time, I think, I'm glad they didn't just throw the drug away, but at least explored the possibility that there might be a subgroup that benefits and the subgroup that really needs another therapy. Because these are the patients who die very early on, and they just don't live long enough for the hematological response to actually benefit them. So even if this is not, reversing the organ involvement, even if it's kind of holding things at a place where the patients can actually benefit from the hematological response, it could really be a valuable addition for the patients. But I think the key thing is, the dangers for the AFFIRM-AL trial is, one, the hematological therapies have gotten so much better with the DARA VCD. So the question is, now the responses, you can get a heme response within cycle 1 in majority of the patients with AL amyloidosis. So the question is, do you really need something to control the organ function for a very long time or not? So that is, I think, the unknown. I worry that the AFFIRM-AL trial with the 150 patients might show a difference, but not be statistically significant because of the change in the hematologic therapy that's going to be used. And it may need a bigger study to actually demonstrate a difference. But I guess we'll know soon enough whether it's actually doing anything or not. But again, I think there's a lot of other interesting molecules being explored. The KL101 being another interesting molecule that's going through clinical trials. And then there are other, what you showed in the beginning in terms of the other mechanisms, trying to either dissolve the fibers or the fibrils, or trying to stabilize them or inhibit their formation. All of them are going to be critically important. But I think, it's a challenging disease. I think the key thing always is getting these patients through the first 6 months after diagnosis.
Sir, I've got two queries here. One, we have only evaluated patients with cardiac amyloidosis, and whereas this drug has an efficiency or has a capability of looking at extracellular deposition anywhere else. So query number one, can we actually look at the benefit of this drug in any other organ other than the heart, maybe a renal or a pulmonary? That's query number one. Query number two, if I have to do the same trial again, and if somebody asks us to do the efficiency of this trial, how would you like, after looking at this information, how would you like to modify the trial if it has to be re-looked at?
Yeah, no, I think the answering your second question, Uday, I think the AFFIRM-AL trial does, conform to the a better design, because now we are looking at the population where we think we might see the maximum benefit. I think the randomization is reasonable 2:1. The power calculations, I think, is an unknown because we just didn't have any data with DARA VCD. So that is certainly going to be a unknown, and we will find out when the trial results read out. But I think in terms of the trial design, I think it's right. I mean, the endpoint is all-cause mortality, and I think that's, it's kind of a grab bag of all different things. But I think that is what is most important, is to try and keep these patients alive for the first 6 months until their hematological response kind of kicks in. So I think the ACM or the cardiac hospitalization, they're all reasonable endpoints. And as you can look at the adverse event profile, right, every one of them is disease related. It's pretty clear. It's not, they're very similar across both arms. They are mostly cardiac related or other amyloid organ related. So clearly it's, what kills people are during those first few months is all organ related and predominantly cardiac. The people don't die of other organ dysfunction typically right away, as long as we can control the disease. So to your first question, will it work in other organs? It probably will. I mean, the mechanism wise, there's no reason to believe it won't work in the other organs. There's nothing unique about the cardiac. And a lot of the preclinical work had been in a relatively tissue agnostic way. The question is, do you really need something like this if you can get the light chains out of the picture with a deep hematological response in the first cycle? How much will this add on to that? And it's all, with these kind of phase 3 comparisons, it's the incremental benefit, right? So if you can get 90% of the benefit with your primary therapy, and if you only need 10% additional effect, then you need a huge number needed to treat to demonstrate the value. Whereas if you have a suboptimal hematological therapy like VCD, then of course, then you have a larger amount of gap to fill in. So you need less number of patients to actually demonstrate the benefit. I think that's going to be the key point here, whether this trial is going to be successful or not, is going to be if everybody in that trial gets DARA VCD as their primary therapy, I am very worried that it's probably not going to show the benefit.
So what are the benefit as far as the quality of life is concerned? Because many of the patients with amyloid is just not the length of survival, but also the quality, which is very important. So what do you feel? Is such molecules, do they have a scope in improving the quality of life for our patients?
I think it, at least based on what we see with the comparisons, right, both in terms of the quality of life scores as well as the 6-minute walk test, and there seems to be meaningful difference in terms of those numbers. So obviously, I think even in the absence of a formal cardiac response, the fact that we are seeing those changes, I think it certainly is very encouraging. And I think it's important. I mean, I don't think it takes away the importance of very careful supportive care management in these patients, especially the initial months in terms of fluid balance, the management of orthostatic hypotension. Those things are very, very important. And this will probably, it'll add on to everything else we do for these patients. It's not going to replace anything that we're currently doing.
So, I was just wanting to, if I'm wrong, my understanding that probably Biratumab is probably quenching the light chains and preventing further damage, and that is contributing to preventing early mortality. Would that be a wrong interpretation of this whole thing?
I mean, the issue is it's quite possible, and I think the fact that we are not really seeing much difference in the hematologic response suggests that at least it's not really removing the light chain from being measured. So that makes it probably not a huge factor here, I think. And again, the mechanism that's proposed, which is macrophage-mediated removal, that is something that's going to happen only in the tissues. So I think even if it has some light chain removal effect, I think it's going to be minimal, because the clones are going to continue to make enough light chains to create havoc. The other interesting part is, again, remember that stage 4 versus other stage. I mean, the Mayo 2012 staging system has the light chains, which nothing else has. And one of the things we don't know is how many people, how much of the light chains are driving some of these issues. So there's that hematological component that comes into that 2012 staging system, which others don't. And again, how much of implications does that have in terms of the heme targeted therapy that we use, right? So DARA VCD is that, obviously, the how much of these people became stage 4 because of the light chains, and if those people are going to be selectively kind of be benefited by a more effective therapy, again, could potentially diminish the isolated impact of the Biratumab too. So those are all the unknowns.
Could there be a synergistic effect also in terms of combining?
So we didn't see difference in heme response, right? We should have seen some difference in the heme response. And the heme response should be very early on, because it's all light chain based.
Right.
And since we didn't see that, at least in the short term, there doesn't seem to be any. Long term, who knows? Maybe a year or 2-year heme response. We won't know because the trial got terminated early.
So, can I ask a question?
Yes, sir.
Yes, please, sir.
Hey, Dr. Verma, how are you?
Yes, Verma, sir, please.
Yeah. So, when we talk of amyloid or any other organ infiltration, even if you take away the infiltrating agent, am I audible?
Yes.
Wow, yes, you are.
Hello?
Yes, very
Yes, we
much.
can hear you fine.
Am I audible?
Yes,
Yes.
very much, sir. Very much.
Hello?
Yes, sir, you are audible, sir.
So, is it possible? Okay, so is it possible that for the effect to, is it possible that really looking at? Because if you have an organ which is already diseased, it may actually not make a material difference in the shorter term. But yeah. Well,
I think, sir, what sir is trying to say is, if I can, add here. So in MLAD, there are two problems. One is the circulating light chains. The other is the light chains which have been deposited in the organ and which is causing organ dysfunction. So even if you are taking out the light chains from the blood, the light chains which are already there in the organ, if you don't remove them, obviously, even if you have achieved a hematological response, the organ dysfunction may not improve. So in this trial, they are actually trying to remove the already deposited light chains from the organs, and they did much to remove the light chains from the blood. So so as Hari said, if we combine the two, if we combine Dara-VCD with this drug, so that means you take out the light chains from the blood also, as well as you do the macrophage removal of these light chains from the organs. Whether that strategy will work in primary amyloidosis or not.
Right. I think the key thing is we know that if people can get into hematological complete response, their organs in general do improve over time. And you can actually see reversal of the subtle thickness goes back to normal, the diastolic dysfunction improves, the strain improves. So it's a question of the time frame. The people who need an organ response to happen within the first 6 months of the starting therapy and especially if they have advanced organ involvement, they just don't have enough time. And that's where I think these therapies will have the maximum impact in terms of accelerating that process of organ improvement. But if somebody has, just isolated renal involvement, they can easily go a year for the hematological response to kick in, and they won't die of it. Yes, it will be nice to have their organs also improve in 6 months instead of 1 year. So essentially, I think what will happen with this is, assuming it has the adequate amount of efficacy in removing those fibrils, is that we will see a much accelerated organ improvement across the entire set of patients. But where it will make a difference to the endpoints like all-cause mortality is going to be the cardiac patients, because others don't just die like that.
So, Dr. Fahima, when you presented the standard of care, so whether it was only bortezomib or what was the standard of care which was given to these patients along with the Bitamimab?
VCD.
All the patients had bortezomib-based therapy, with almost
Fibroid.
90% having VCD, sir.
VCD.
Yes.
Mm-hmm. So maybe, as you said, the other strategies of dissolving the light chains from the organs may work, because now currently we have a Dara-VCD, which is kind of one of the very good regimen to take out these light chains. And as you said, some of the organ improvement also happens. But, we still need some drugs which can, take out the light chains from the organ or from the tissues also.
What I noticed was, sir, even the hematological response at 3 months in VCD with historical controlled had a better hematological response than what this post-hoc analysis is showing. So we cannot really comment on it because it becomes a post-hoc analysis. So that's something that I wanted to know, what could have been the reason. Despite VCD have been given for 90% of the patients, we did not see a hematological response that is on par with historical controls.
Yeah, it's hard to know because, again, a lot of the historical controls are single-arm trials and highly selected patients. So there's bias in both the bias that's introduced by the post-hoc analysis and the bias that's in the phase 1 or in the single-arm trials that have been reported before.
And if I may, sir, the other thing what I noted was the cardiac response as assessed by NT-proBNP in the phase 1-2 trials were impressive. Even with 16 patients, they had around 60% cardiac response. Why that was not seen in these cardiac stage 4 AL amyloidosis patients, that also I could not understand what could have happened here. That was also not
it's hard to know.
on par.
I mean, part of the reason is probably the the phase 1-2 trials included everyone, right? So here we are looking specifically at the phase 4 or the stage 4 patients where the responses again could be a bit more delayed. And because of the way this trial got terminated and not having a comprehensive set of information, it becomes a little bit difficult to extrapolate. So I guess we'll keep
Thank
our
you.
fingers crossed until the trials read out.
So anything upcoming in the ASH? Anything on the amyloid?
I'm not sure. I don't remember all the presentations. I know there are a couple of those amyloid ones with the, again, data-based strategies. There's one with teclistamab. It's a small series that's being presented. So all other, mostly plasma cell-directed therapy approaches. But the KL 101, there are 2 different studies ongoing.
Thank you all, sir. We had a wonderful discussion on the article. We were actually very hopeful with this molecule to start off with almost around a year back when we were hearing about this molecule. But yeah, I think we are still not at the end of the tunnel. We need to wait for some more time to get something more meaningful, either maybe from this molecule or from other molecules. But to go ahead, today we have got some interesting discussion. Now I would invite Dr. Sumit Mith, who is the Associate Prof at ACTREC Mumbai, to present the compilation of the Indian data of amyloidosis. So what all has been published. So Sumit has done a phenomenal job in compiling everything to put it together. But Sumit, I would request you to wrap it up in 15 minutes, please. So over to you, Sumit, please.
Am I audible, sir?
Yeah, you are.
Is my screen visible, sir?
Yes.
Thank you. Firstly, a big thank you to Team Image for giving me this opportunity. So today I'm going to present Indian data on amyloidosis. So I began this with a thing in mind, or a myth in mind, that probably there is no data on amyloidosis from India, or there is paucity of data. Just like the Cricket World Cup final, we should be prepared for surprises. And PubMed throws you up with 827 results when you search amyloidosis in India. But when you try to tease out what these articles are, majority of them are case reports. These are primarily by physician residents and by specialists from each respective specialty. Hardly 10% of them comprise case series and original articles, and they have been considered together because majority of the original articles have patients who are in single or double digits. Review articles, I was fascinated to see that there are so many review articles, but majority of them are preclinical, written by biochemists, anatomists, biophysicians, where they have concentrated on protein folding and the dynamics of proteomics. And last is others, wherein maybe the papers are not from India, the authors are not from India, and at times amyloid is not the prime focus of the article, and it is just one of the many causes in the heading of the article. So along with the case series and original articles, I have reviewed the published abstracts, and we will present this small presentation. So first, let us look at the AL amyloidosis as a whole, where they're not looking at any specific system per se. So the biggest data for this comes from AIIMS New Delhi, from Department of Medical Oncology. 59 patients over 21 years with a median age of 52 years. This is much lesser as compared to the Western data. Weight loss was the most predominant clinical feature, and it is important for students to understand that weight loss is difficult to discern in patients of amyloidosis, primarily, especially if they have pedal edema because of concomitant proteinuria. This was the most common manifestation, followed by pedal edema, fatigue, breathlessness, so on and so forth. The median duration of symptoms was 9 months, with majority of patients presenting in a poor performance status. Cardiac was the most common system involved, followed by renal and others. The median M-band, as we expect, it is only 0.6 grams. Predominant number of patients present with proteinuria and increased bone marrow plasma cells, with the median percentage of being 10%. When we look at the treatment and outcomes data, this was an abstract only. 40% patients were treated with bortezomib-based therapies and 35% with melphalan-based. 9, which means 16% underwent an autologous stem cell transplant, and majority of them received a post-transplant maintenance. Most importantly, at a median follow-up of 5 years, the median OS was 74 months. So when we see a data wherein the median duration of symptoms is 3 quarters a year, and the most common cardiac system is a system of involvement, we expect a lesser median survival. But this was a median survival of close to 6.5 years and more. So a full paper of this is not available, but I would be intrigued to know that how did they label cardiac involvement in their patients. One more possibility could be that the median age was only 52 years, which is a much younger cohort as compared to the Western data. Coming to another data from Gangaram Hospital, 27 patients over a period of 6 years with a median age of 59, biopsy-proven amyloidosis along with clonal plasma cell proliferative disorder. Importantly, this was also an abstract and no per se amyloid typing was done in these patients to qualify whether they were AL or other types of amyloidosis. Renal was the most common system, followed by cardiac and GI tract. Lambda light chain, as we expect, is the most common light chain which is involved in amyloidosis. Out of 27, they have treatment data for 14 patients, and the most common regimen was BCD. And at a median follow-up of just more than a year in 14 treated patients, 64% were alive, which means 36% patients did die at a median follow-up of just more than a year. This was an abstract only, and amyloid typing details were not available. Now, when we have paucity of data, we can always go towards myeloma and get out some data of AL amyloidosis, especially in patients of myeloma who present with renal failure or renal impairment. This is the data from SMS Jaipur in 2022, published as an abstract, wherein 43 out of 144 patients did have renal involvement, and they did biopsy all the patients of myeloma who had renal involvement, and 30% of them did have AL amyloidosis as a cause of renal involvement or renal dysfunction in their patients. This is data from PGI Chandigarh, where they suggest that lack of renal recovery predicts a poor survival in patients with multiple myeloma with renal impairment. Over a period of only 1.5 years, 216 newly diagnosed myeloma patients were recruited, of which 91 had renal impairment, which means a creat of more than 2, or EGFR as per MDRD's EPI equation of less than 40. This was a bad cohort of renal impairment, where the median age was for 60 years. ECOG PS was 3 to 4 in 75% and more patients. Majority had high risk cytogenetics and dialysis at presentation in 40% patients. Importantly, while those with primary amyloidosis were excluded, but they did biopsy a significant proportion of patients where definite cast nephropathy was biopsy proven, and suspected cast nephropathy was based upon high levels of free light chains or predominantly a non-glomerular proteinuria. Amongst those with definite cast nephropathy, half of them had concomitant involvement with MIDD, other causes which included AL amyloidosis. Now, as a desperate measure in renal involvement patients, they did give quadruplet, which means VCTD up to a few patients. However, on subset analysis, patients who received triplet had better improvement in renal function versus quadruplet, which was not statistically significant. Coming to primarily those patients who are focused on renal involvement and renal impairment. So this is the most, or one of the most important seminal papers of patterns of renal amyloidosis in Indian patients, published way back in 1981 from PGI Chandigarh. 233 patients, 1% of the post-mortem patients and 8% of all renal biopsy patients, where the diagnosis was based on apple green birefringence or Congo red, or a typical fluorescence with thioflavin T. In those days, serology was not available, amyloid typing was not available, and that is why amyloid was labeled as primary after careful evaluation on history and examination ruled out as secondary amyloidosis. And majority of them did have a secondary amyloidosis in 87% of the patients. Importantly and intriguingly, when you look at a secondary amyloid cohort, time between a disease and the first evidence of myeloid is close to 7 years. And when you look at only the post-mortem patients, after kidney involvement, majority of the patients did have a reticular endothelial system involvement on post-mortem examination. Again, same limitations, no serologies and amyloid typing in that era. Now, when we move back from 80s to the 90s and 2000s, this data is from BHU Varanasi. 2,500 renal biopsies over a 19-year period, 90s and 2000s, where typing was done by acid-effect potassium permanganate as IHC was not available. And when we compare the 90s and the 2000 group, the incidence of amyloidosis in all the kidney biopsies was more or less the same. However, it was a more female predominant population in the 2000s group. In the 2000s group, while edema was also the same clinical feature as compared to the 90s group, more number of patients were diagnosed with amyloid at a lesser degree of proteinuria and more renal insufficiency as compared to the 90s group. And when you look at the causes of renal amyloidosis, the causes of renal amyloid in the 90s group was predominantly infections, whereas later it was predominantly autoimmune disorders. This would explain why females predominated in the 2000s group. However, when you look at the amyloidosis, it was the same, 11% and 13%. And they concluded with the fact that TB still remains the most common cause of renal amyloidosis, and this is probably because of the A amyloidosis in both the groups. Coming to the data from Ahmedabad in the 2010s, 40 patients over a period of 2 years with biopsy-proven renal amyloidosis, wherein accounted for 5% of our renal biopsies. Median age of much younger, 44 years, in contrast to the Western data where the median age is 63 years. As we expect, nephrotic syndrome is the most common clinical manifestation with a 24-hour proteinuria mean of 6.4 grams. All the biopsies was reported by a single nephropathologist, and they did have amyloid subtyping by IHC in the AA and the light chain in the immunofluorescence. They labeled amyloid as light chain related either by direct examination, which means in 50% patients when they proved that it was light chain related because of immunofluorescence, or when they have evidence of a monoclonal plasma cell proliferation disorder based on serology or plasma cells in the bone marrow. What do we see? In 40 cases, 72% were AA and the 18% were AL amyloid, which means that the ratio of AA is to AL is 4:1. This is in contrast to the Western data where AL is to A is almost 12:1. When you look at the A, as we expect, TB is the most common cause. But intriguingly, the time period between TB and amyloid was in half of the patients more than 3 years. In a majority of patients, they did not have any evidence of active tuberculosis, and a major of them had actually completed a TB treatment per se. When you look at the AL amyloid patients, a couple of patients had proteinuria, which was very significant. A couple of them had renal failure involving dialysis. Some had cardiac involvement, and one had myeloma. Now, coming to the last renal data from AIIMS Delhi, 48 patients out of close to 4,700 kidney biopsies, all those who had renal involvement with some amount of monoclonal protein, with or without a clonal lymphoproliferative disorder. AL amyloidosis accounted for close to 70% of all cases of MGRS in their cohort, with a median age of 50 years, and the treatment data was available only in 12 of the patients, of which only 9 were followed up, and the most common regimen was VCD as we expect. So when we look at AL renal involvement and now the most important cardiac involvement, as we ascertain, is the most common cause of mortality in these patients. The largest data is from South India, 98 patients over 18 years from 2 tertiary cancer care centers in Kochi. AL amyloid along with cardiac involvement, where the amyloid is proven majority of the cases from the extracardiac sites, and it was suspected on the basis of cardiac imaging, that is a cardiac involvement. A thing unusual was the lambda light chain restriction was only in 56% patients, which is to the tunes of 80% majority of the series, and roughly 1/3 of the patients had bone marrow involvement with clonal plasma cells. When you look at the cohort of treatments, half of the patients did receive Cybordi, that is VCD, and the other half did not receive because this was over a median period of almost 20 years. The duration of symptoms was 3 to 6 months, and they were very elderly patients. Importantly, a majority of the patients in the VCD cohort were in Mayo class 3A and 3B, in contrast to the patients in the non-VCD cohort. When we look at the EF less than 50% baseline versus post-induction and improvement versus treatment, 81% EF less than 50 at baseline in the VCD comes down to only 23% after VCD treatment. In contrast to non-VCD treatment, it does not come down by that much of a significant difference, and it is coming down by 20%. So they told us that a median survival with respect to progression-free survival was better in the VCD arm, and there is lesser worsening of the ejection fraction and the diastolic dysfunction in the VCD arm. Unfortunately, like similar data, amyloid subtyping data is not available, and this was also an abstract only. Coming to data again from PJ Chandigarh, 25 patients over a period of 14 years, wherein they had AL amyloidosis and cardiac involvement was proven by endomyocardial biopsy in all of 25 patients. Symptomatic heart failure in 23 out of 25 patients. Most common treatment regimen was, as expected, VCD. 44% did have extracardiac involvement. Majority had lambda light chain restriction, and a few proportion had concomitant myeloma. A dismal outcome. Overall response rate of only 44%, and a median follow-up which is less than 6 months. 88% have died. Importantly, half of them within one month of treatment initiation. This tells us this is the real world data wherein those with cardiac involvement have a dismal outcome in our country. Now, this is a bit disproportionate data from AIIMS New Delhi, primarily from the Department of Cardiology. 40 patients, much younger cohort, 51 years. Majority of the patients did have NYHA class 1 and class 2, which means class 3 and class 4 patients were very less. They're diagnosed by imaging and endomyocardial biopsy, which is suggestive of amyloidosis. And the median survival was 25 months, which is much better than the previous cohort. Importantly, the the amount of patients who were AL amyloidosis in this cohort were only 4. And subtyping again was not done. And AL amyloid patients were treated with melphalan, prednisolone, and not a bortezomib-based regimen. Coming to the last data from DMC Ludhiana, a small cohort of 13 patients with a median age 65. Again, a biopsy-proven amyloidosis along with cardiac imaging and a plasma cell dyscrasia. As per a personal communication from Dr. Subir Singh, they did amyloid typing by IHC in this data cohort. Roughly 60% had AL amyloidosis. VCD was the most common induction regimen, and the median survival was just more than a year to the tune of 15 months. At a 1.5 month time point, half of the patients have died, and those who are alive, a majority of them still have NYHA grade 3 symptoms. This is an interesting paper from AIIMS New Delhi, wherein they have told that degenerative disorders like aortic stenosis, cardiac amyloidosis both increase with age. And when they looked at only the aortic stenosis patients of more than 65 who underwent a surgical aortic valve replacement, and they looked at the amount of patients who had cardiac amyloidosis, that is ATTR type, either on the basis of the pyrophosphate scan or on the basis of those who underwent a biopsy from the basal interventricular septum or the excised native aortic valve. Out of 46 patients who underwent a valve replacement, 32 did undergo a pyrophosphate scan, and 10% had concomitant ATTR amyloid. And those who underwent a biopsy, none of them had amyloid in the septum, whereas 70% did have it in the aortic valve per se. And amongst those who don't have in the aortic valve, half of them had ATTR amyloid. So this tells us that yes, isolated valvular amyloidosis in severe aortic stenosis is much more common in India than what we expect. Coming to the rare neurological papers, a biggest paper from CMC Vellore, wherein they have included patients of chronic peripheral neuropathy, plus who on evaluation did develop or evaluate or develop a monoclonal protein or plasmacytoma. They included only indoor patients, and outdoor patients were not included. 74 patients over a period of 10 years. And those who were previously diagnosed with plasma cell dyscrasia and subsequently developed neuropathy were not included, which means that patients who developed bortezomib neuropathy or something else were excluded. Patients had symptom duration of at least a year. Sensory motor was the most common type. Demyelinating was the most common subtype. And as we expect, IgG lambda was the most common isotype with respect to heavy and light chain, respectively. So among 74 cases, as we expect, most common cause was MGUS and POEMS, and the least important cause or the least common cause was AL amyloidosis. But when you look at a subset of AL amyloidosis, all of them presented with small fiber neuropathy with autonomic involvement. They had normal NCV studies. Even the nerve biopsy did not show amyloid. They showed amyloid in other organ biopsies. Unfortunately, treatment data was available in each of these 3 patients. Coming to the localized amyloidosis, which is per se not any specific organ involvement or a systemic amyloidosis. Most common is in the laryngopharynx, in this case series of 7 patients from Medanta, Gurugram. Almost all of them had AL except AA in 1. 4 of them did undergo a microscopic laryngeal surgery with a carbon dioxide laser. And in those patients who did underwent this surgery, at a median survival of 3 to 18 months, which was very variable. An interesting case series of orbital amyloidosis from Sankara Netral in Chennai. 33 eyes of 26 patients. Most common site involvement was eyelids, presenting as either ptosis or a localized swelling, or orbital swelling, or conjunctival swelling, or either of the lateral rectus or superior rectus swelling in these patients. Unfortunately, IHC was not done in majority of them. They did undergo debulking, and at a median half-survival follow-up of close to 18 months, there were only 3 recurrences in 33 eyes. A very rare site, vitreous amyloidosis. 2 families, 5 patients, 10 eyes. Median age of 32 years, commonly presenting with painless loss of vision plus floaters, and most importantly, a family history. They did exclude other vascular causes. Concomitant amyloidosis was present in few patients. One interesting fact was, on slit lamp examination, they got something which is called as pseudopodia lentis, which is posterior opacification of lens in the capsule, and glass wool vitreal opacities on fundus examination. And this was the waxy paper-like concentration of the vitreous on intraoperative findings. When they did a genetic sequencing of these patients, they found a very rare F33I mutation. And when they did a vitrectomy, they found that in all the patients, there was improvement in visual acuity at a median follow-up of 1 year. So to summarize our Indian data of amyloidosis, yes, large data is available, but unfortunately as only abstracts with absence of data on amyloid typing per se. Renal amyloid accounts for 5 to 8% of all the renal biopsies. AA renal amyloid because of TB is still more common than AL amyloidosis in India. When it comes to cardiac amyloidosis, yes, VCD data for induction has been the most commonly used induction regimen in our country, with a median survival of 6 to 15 months. There was one paper from AIIMS New Delhi which suggested that you should look out for ATTR amyloid even in valvular AS patients. 5% of patients with paraproteinemic neuropathy, as per data from Vellore, do have AL amyloidosis. And there is a real need to collaborate multi-center data and prospective trials. And this is probably the right forum to say so. Thank you.
Thank you. Thanks a lot, Sumit. There were a lot of questions in the beginning when I chose you to summarize this information, that who is the best person in the country to do this. And after listening to your talk, I doubt if there is anybody better than you to summarize this. A phenomenal job. And as we discussed in the morning, this should be written up, and we will write this as a summary from our country as part of an image paper, a review paper, consensus paper. What is our data from our country? But as you rightly pointed out, we'll chase all those people who have presented abstracts but never written articles, including myself. Pankaj sir is laughing at it. So where we will convert the abstracts to articles, but we should chase others also, because it's important to have national data. And when they had presented abstracts, it's a good thing that they should write it up as an article. And with so many international fraternity with us who are editors of big journals, these are some things which can actually showcase what's happening in our country. So without further ado, because we have got 2 more aspects to be covered as far as the current day's program is concerned, I'm not taking
Uday, just I'll ask question
sure.
to Sumit. So these biochemical, lot of IITs, Indian Institutes of Science, they are doing this amyloid typing, and do you find any significant paper or some research coming out from these institutes, IITs, Indian Institute of Science, ICERs, and so on?
There is a lot of data, and to be honest, it is so preclinical that it is difficult to decipher for me at times. There was one paper from Indian Institute of Science wherein they have looked on patients of renal amyloidosis, and they've done proteomics in them. That was a paper which was quite interesting to me. And there is a lot of data on use of these EGCG, curcumin, and few other plant derivatives for inhibiting the amyloid fibril formation. And what do you say that when they conglomerate together, that fibril formation. So maybe if a lot of them have worked on these anti-amyloid fibril therapies, especially from the plant derivatives available in our country, we should collaborate with them, which will be helpful for our patients.
So
maybe we can.
Pankaj sir, what I have done is, because I realized this when I was talking to Sumit in detail. So the next month in the General Club, I'm actually bringing up Dr. Shiva. He's an ex-person. He has done his complete academics in US, and he has come back to India. He's a master's in biochemistry, but he has a lot of work in amyloid. So he is interested to summarize the way Sumit summarized the clinical data. We will have the next month in the Journal Club a summary of all the preclinical data, which I have requested him to do it for the next month. So after ascertaining his availability, we'll have one session on preclinical also, maybe as part of Journal Club or as part of the IMC 2024, wherein we'll give stage for these people to summarize it and make it in an assimilated form for us, for the clinicians, out of which where we can collaborate with them, or it can be used for the clinical platform where we can convert it at a bedside thing. So I have actually approached 2-3 people for this, sir. So hopefully we should get at least one of them to help us out on that.
Sure.
So going ahead, sir, Hari sir, with your permission, I'll just go ahead with the quiz, because already we are delayed by around 15 minutes. So don't mind, I'll just continue the quiz, sir. Taking it further, quickly, I'll just go through the 5 questions. Neerav, are we ready to take this forward?
Yes, sir. Good to go.
Okay, good. So the first question, today we have heard a lot about amyloidosis. So the first query is, how do we diagnose amyloid, systemic AL amyloidosis? So how do we go about it? So I want various options here, and I want, as per the IMWG criteria, which of the following are not a criteria for diagnosing systemic AL amyloidosis? So option A is presence of amyloid-related systemic syndrome. Option B is congruent staining showing positive amyloid staining. Option C is 3 is mass spec or immunoelectron microscopy-based diagnosis. Option 4 is monoclonal plasma cell proliferative disorder. And option 5, if you feel that all of these are the criteria, then just choose the option 5. That means that all of these are mandatory criteria, so there is no exception. Okay, because of the paucity of the time and as we have overshot time in the two beautiful presentations, I'll go to the next question. Now, as you could see here, a patient with systemic amyloidosis also found to have GI amyloidosis in a biopsy from the lips and also biopsy from the rectal area was found to have systemic amyloidosis fitting into the IMWG criteria, and was found to have these waxy raised hemorrhagic lesions below the nose, around the lips, and around the eyes. What do you feel is the treatment? What do you feel is the diagnosis of these people? Do you feel this is herpes zoster? It is herpes simplex? Are they pure, just plain simple amyloid deposits? Or because the patient had got amyloid gastropathy, so there was some deficiency of nutrients, micronutrients, and these are manifestation of micronutrient or vitamin deficiency. And or could this be molluscum contagiosum? Okay, going to the next question. All of the following are used in Mayo 2012 staging for AL amyloidosis, except troponin, BNP, DFLC, FLC ratio, or if you feel all these 4 are components of staging, then just choose 5. That means you don't agree with any of these options. All of them are part of the Mayo 2012 staging. It's important to know the staging for AL amyloidosis because most of the treatments or the prognostication, in fact, more than the therapy, is based on the staging. The overall survival can directly be predicted based on the stage of the AL amyloidosis. Going to the 4th question, the trial which was beautifully presented by Dr. Fahima. So this particular trial was stopped for futility. So in statistics, there is something known as a futility analysis. So what are the various reasons for stopping a trial for futility? Option A, or first option, evidence of no treatment effect by scheduled interim analysis. Option 2, substantial missing data that would unacceptably undermine the trial conclusions. Option 3, event rates are too low to support meaningful comparisons. Lack of funding or finances to continue the trial. And if you agree that all of these can be the causes or reasons for futility, then choose the option 5. The last question, again from the article which was presented, the VITAL trial on the role of Vitamimab has shown benefit in post-hoc analysis. In which of these category of patients? So has it shown benefit in percentage of all-cause mortality in stage 4 AL amyloidosis? Benefit in time to all-cause mortality. The first one was percentage of patients having all-cause mortality or the mortality, or second is time to all-cause mortality in stage 4 AL amyloidosis. Option 3, benefit in time to all-cause mortality in all stages of AL amyloidosis. Benefit in the primary composite endpoint. Here, the primary composite endpoint was time to all-cause mortality or centrally educated cardiac hospitalization after the first dose infusion in stage 4 AL amyloidosis, or benefit in the primary composite endpoint in all stages of AL amyloidosis. So if you all people have answered this, I'll quickly go to the answers. And in the meantime, I request Neerav to quickly look into the winners.
Yes, sir.
Coming to the... Yeah, Neerav, can I go to the answers?
Please, sir, please.
Okay, so the diagnosis of systemic AL amyloidosis, the IMWG criteria, all these 4 are mandatory criteria. So a person need to have all of these criteria to label a patient as systemic AL amyloidosis. And the biggest problem as far as our country is concerned is point number 3, wherein the lack of a mass spec based proteomic analysis or immunoelectron microscopy uniformly available across the places to identify the type of amyloidosis. So this is the IMWG criteria. So these are the 4 criteria, and it's mandatory to have all these for diagnosing a patient as AL amyloidosis. The second one, these are amyloid deposits. These are not herpes zoster or herpes simplex. The Vacci-Rage lesions are common manifestations at mucocutaneous junctions. As you would see, nose or the nares is a mucocutaneous junction. Lips are a mucocutaneous junction. And at the eyelids, as they Dr. Sumit had shown some dermatological data. So that's another location for amyloid deposits. So the dermatological manifestation in AL amyloidosis can be present in up to 40% of the individuals, and they characteristically present as waxy appearing papules, which are often translucent and may resemble a vesicle or a bulla. And you can have other forms like nodular amyloidosis or purpura is again a dermatological manifestation. The non-specific findings include alopecia, nail dystrophy, or macroglossia. So this is how it appears like, other than the photographs which Dr. Sumit has shown. So this is at the eyelid, this is in the feet, this is on the face. So these are the various manifestations of a dermatological manifestation of amyloidosis. The photographs which I've shown, all of them are actually AL amyloidosis patient having these findings shown as case reports in various journals. Coming to the third one, that is which of the following are used in Mayo 2022 except. So the Mayo 2012 staging uses troponins, the BNP levels, and the DFLs. It does not use SFLC ratio, the ratio of kappa is to lambda for staging the AL amyloidosis. So the correct answer is SFLC ratio here. So we have staging starting from Mayo 2004 staging. Then it was modified by European modification. Then we have something known as the Mayo 2012 staging. Now, this is one of the commonest staging system which is used across the world and in various trials. And in fact, the author is sitting with us here in the session today. So we have troponins, BNP, and DFLC. And based on these are considered as 3 risk factors. So if there is no risk factor, it is stage 1, 1 risk factor stage 2, 2 stage 3, and all 3 risk factors being present is considered as stage 4. And as you could see that the hazard ratio for death is directly proportional to the stages. So the higher the stage, the higher the probability of death, and lower is the overall survival. Now, when we talk about futility or the futility analysis, so the first 3 answers options are the valid reasons for futility, but whereas lack of funding or finances is not considered as a reason for futility. So futility actually used to be used majorly in meta-analysis. So when we used to have initially very high good results in some studies, and over a period of time when people try to replicate, you find that, as you see here, that there is no advantage. So then it used to be known as futile. When you use a composite Z value and required numbers, then you find that over a period of time, you find that the study was futile. Then you find certain studies which did not show initial benefit, but when you accumulate the studies and get to an adequate number, then you find that those particular studies are good. And to actually make sure that you don't misinterpret a single study, so there is something known as the modification of the statistical significance based on the numbers that you are trying to study. So you have that in the meta-analysis. And nowadays, we use this dual curve technique to identify whether there is futility present in meta-analysis or not. Why I brought this here is futility is a term which is very commonly used in meta-analysis. But when we use for individual trials, so when there is a scheduled interim analysis, so either the study is so good and you have got such a beautiful mortality benefit that people might stop the study at interim analysis to say that the benefit has been compared to the, that you don't need to further study any further and you can get approvals. At the same time, you can have futility. That means the results have been so bad that continuing the study will not add any benefit. So at the interim analysis, scheduled interim analysis, you actually stop the study either for excellent efficacy or for a futility if it was found. So this particular article which was presented today is one of those articles wherein it was stopped prematurely at interim analysis because of futility. This is how you look at futility gate. You have interim analysis 1, interim analysis 2, and then you have a futility analysis over a period of time, and then you look at various time points to look at the futility. Now, coming to the last question, the VITAL trial. So it did show in a post-hoc analysis benefit in time to all-cause mortality only in stage 4, Mayo stage 4 AL amyloidosis patients. So that's the right answer, which was beautifully covered by the presenter today. So these are the various things. So I think with this, I will announce the next month General Club would be on 28th December. This time we are going to concentrate on pre and paraclinical. The presentation would be by the pathology team from Tata Medical Center, Kolkata, where we'll be talking about the diagnostics of amyloidosis. And thereafter, followed by that, we'll be having again a 10 to 15 minute session about the summary of the national data on amyloid diagnostics and the preclinical papers from our country. So I would like all of you to join us on 28th December, 5:30 p.m. And I would like to say thanks to the national team, the presenters, and special thanks to Dr. Shaji for taking out time early in the morning to join us and give his insights into this particular article. So I thank all of this, and I would like to give the stage back to Nirav for announcing the results. Yeah, Nirav, you can announce the results.
The name is Dr. Bibin Francis from Jubilee Mission Medical College, Thrissur, Kerala.
Can you say it again, once again, clearly?
Dr. Bibin Francis from Jubilee Mission Medical College, Thrissur, Kerala.
Wonderful. Heartiest congratulations to you. So you would get the Amazon voucher within a week's time and a certificate from the Indian Myeloma Academic Group. And congratulations for winning the quiz. So I would now like to hand over the stage to the President of Image, Pankaj sir, for his final concluding remarks, please.
No, I think first of all, thanks to Shaji who could join us and for this wonderful review of the journal. Fahima, who presented the journal very well. Thank you, Fahima, and Sumit, who did the wonderful job of collecting the data. So hopefully people who have joined us, they will continue to join us on the 4th Thursday of every month. So next, it would be probably 21st of December. And then the image conference, which is coming up from 12 to 14. So we have a special abstract sessions for amyloid as well as for Waldenstrom. These 2 chapters we are launching in the image conference. So with that, I thank you very much to all of you and have a good day.
Thank you, sir.
Thank you, sir. Thank you.
Thank you.